and welcome to And So Much More. I am here with Drew White, who is a psychiatric nurse practitioner here at Centra Health over in the Lynchburg General Hospital. And he is within this larger service line that we call psychiatry behavioral services.
Yeah, psychiatry and behavioral health.
And behavioral health services.
Yeah.
So first of all, thank you so much for being here. I know you have a very busy day, very busy week. But I would love for you to just let us know who is Drew White and what brought you to Centra.
Okay. Yeah, so I've been with Centra since 2009. And I've occupied many roles in that time. In 2012, I started working on our inpatient child and adolescent psychiatric unit. And that's for kids between 5 and 17 years old.
Okay.
And that's at Virginia Baptist Hospital. And when I was there, I was a counselor or a mental health counselor, and the nurses and the doctors looked like they were having all the fun. So I initially thought I was going to be a therapist, and then I started working in the hospital and saw, like I said, the nurses and the doctors. I really liked what they were doing. It seemed fascinating. So I went back to school for nursing, went to University of Lynchburg to get my nursing degree. And then shortly after I finished there, I started working on that same unit, the child and adolescent unit, as a nurse, while I went to grad school at UVA for my master's and my psychiatric nurse practitioner degree.
Wow.
Yeah.
And so here you are. This is, all of our service lines are so vitally important, but we just finished our community health needs assessment at the end of March, and we talked about it constantly because of how important it is to learn what are the top needs within our community. And mental health has been identified year after year after year after year. And so we are primarily going to have a conversation around suicide awareness, but I also see how mental health, and we were kind of pre-gaming a little bit before we started talking, mental health touches everything. And I think that can be almost a common misconception. So why don't you tell us a little bit about that from a really, take a step back and look at the big picture.
Yeah, so you're right. The community health needs assessment continually points out the need for mental health services in our community. And I feel like that was just certainly exacerbated by the pandemic. Across the board, we have seen increases in anxiety, depression, substance use over the last few years across all age groups, and so that's very important. And as far as kind of what we were talking a little bit about before we got started here is there's a connection between the mental health and the physical health too. And my role at Lynchburg General Hospital is I'm seeing patients in the emergency room, in our emPATH unit, which we'll talk about a little bit, I'm sure, and then as well as the inpatient medical floors when people are admitted to the Lynchburg General Hospital or our outlying sites for a primary medical issue, but also have a mental health or psychiatric need. I'm following those patients while they're in the hospital too. And what we see is when your mental health and your psychiatric needs are being met and addressed proactively, you heal quicker while you're in the hospital. The length of stay is decreased. And additionally, tied into that is when your mental health is not being well managed, we see patients and people in the community have more medical issues related to that. So an example I used earlier was like if someone has a severe mental illness like bipolar disorder or schizophrenia, as well as a medical issue like diabetes, if their schizophrenia or bipolar disorder is not well managed and they're not staying on top of that, then they're likely not going to be taking their insulin correctly or checking their blood sugars. And so then you see that person in the hospital more frequently for medical needs. And so what we're trying to do with my service that we have here with the service, it's called consultation liaison psychiatry. That's when you're in the medical setting practicing psychiatry, is we're trying to be more proactively managing the acute and subacute mental health needs of that population to help them heal quicker.
Okay.
So, yeah.
Wow. So day in and day out, you're sitting down with many patients, and you're called in as a, either it's chronic, you're seeing patients over and over, or, there's just something bigger going on here.
And a lot of times when people are medically admitted, there's a certain level of psychological stress that accompanies that.
Okay.
But also, too, there are acute psychiatric issues that arise when someone is admitted medically, like delirium. A lot of times in the elderly, there may be an underlying neurocognitive disorder like dementia. And then that person comes into the hospital for a surgery, a procedure, and they get given anesthesia and other kind of medications that can cause disorientation. And they don't recover from that like you or I would. They're older. It takes them a little while to bounce back from that. And so there may be a period of time where they're in the hospital and they are confused, disoriented, can sometimes become agitated, sometimes combative. And so in those cases, I'm called in to kind of help manage their medications and look to make sure there's no interaction between the medications they're on that could be exacerbating the issue and those sorts of things. And then additionally, we've got patients, severely mentally ill patients, like I said, also become physically ill and they end up in the hospital for things. And while they're in the hospital, the primary medical team who's managing their care appreciates, us kind of helping along to make sure that there's no decompensation of their psychiatric mental health while they're in the hospital.
Wow. So the whole body is considered from your mind to the physical aspect.
Yeah.
And so important. You did mention emPATH, and I'm very curious. emPATH has been, I'll let you explain what emPATH is right now over at Lynchburg General.
So emPATH, it stands for Emergency Psychiatric Treatment and Healing, and it is a model of care, emergency psychiatric care that was started in California by a emergency psychiatrist named Dr. Scott Zeller. He's been a champion of this model of care, and it's starting to catch on across the country. We were actually the first emPATH unit, I know, in Virginia, and I want to say on the East Coast.
Very cool.
And the goal or the objective for emPATH units and our unit is we used to have two options. When somebody would come into the emergency room with a mental health crisis, we had two options. We could admit them to an inpatient psychiatric unit, or we could discharge them. And what studies have shown, multiple studies over the years have shown that approximately 75 to 80% of patients who arrive to an emergency room in a mental health crisis could avoid inpatient hospitalization.
Wow.
75 to 80% of people who are admitted across the country to inpatient psychiatric units could have avoided that had there been an alternative level of care in place in that community. And so what emPATH essentially is it's observation. Now we have a third choice. We can admit a patient to inpatient psychiatric treatment. We can discharge them, or if we're not quite sure what needs to happen, say we don't have enough data yet, we don't have enough information, we can keep them. And so that's where emPATH comes in. And we don't just observe and keep them in a holding pattern. We start treatment. And so what we do, the goal is to, emergency rooms are not equipped to really manage mental health crises. They're equipped to manage physical crises, but really if you're in a mental health crisis and you arrive in an emergency room and, you're told you need inpatient treatment, and then sometimes the length of stay while you're waiting for a bed could be 4, 5, 6 days. Historically, those patients would just sit there in the ER for 4 or 5 or 6 days, not really receive any treatment. What we're doing now with emPATH is as soon as the patient comes through and it's determined that they need mental health treatment, we're trying to get them over to the emPATH unit. We're evaluating them. determining kind of what their needs are. We're adjusting medication, starting medication. And what we're finding is within 24 to 48, sometimes 72 hours, that patient who previously would have needed inpatient treatment, we're able to discharge to the community. A big part of that is case management. We have a case manager on the unit who, the minute the patients come over from the main ER, she's working on getting them follow-up appointments and getting them connected to resources in the community. We have group therapy sessions on the unit. We have individual therapy. So we're starting treatment quicker and we're stabilizing patients quicker. And what the data is showing right now, we've been open 7 months, and about 88% of the patients who have come through emPATH have been able to be discharged to the community without a inpatient hospitalization. And that's not to say that there isn't a role for inpatient psychiatric hospitalization, but it can be disruptive. Being in the hospital, whether it's for a medical reason or for a mental health reason, it can be disruptive to your job. You miss work. You're away from your family. You could, theoretically miss paying your bills. You could be, you miss work for a week. You could be short on rent, on the first, and then that just compounds your anxiety and your stress. So if we can stabilize people in 48 hours and we get them connected to services and we avoid an inpatient hospitalization, that does two things. Is it helps them get back to their life and addressing the things they need to address. And it also, we have eight beds on emPATH. So that now means we have 8 beds on our inpatient unit for higher acuity, sicker patients who previously wouldn't have had anywhere to go.
Yeah. So it has spread things out more evenly, but also more appropriately.
Right.
So that not any particular people group is waiting obscene amounts of time, which on some level in the emergency room is common and normal.
It's just the nature of there's I could talk for a few hours probably about the state of the mental health care system across the country, but I think it's important to emphasize what we're seeing here as far as boarding and length of stay for. Another point let me hop back to the results of emPATH.
Sure.
Is the length of stay for behavioral health patients in our LGH-ED has, since emPATH opened, has decreased by 20%. Okay. So because we're moving things along quicker, we're getting people where they need to go quicker, they're not waiting as long. But ED boarding for mental health patients across the country has been increasing exponentially over the last decade, 10 to 15 years. And it's because there's less, there's a lot of state-funded psychiatric hospitals across the country have closed for various reasons. And so that has put the onus of managing this crisis kind of on the private healthcare system. And so that's where emPATH comes in, is where everybody's trying to figure out ways to better address the needs of this population. And this is one way to do that. Yeah.
I love how passionate you are about this. Clearly, this is.
I tell people all the time, especially students, when I have students come through, or we've had several people interviewing where we're trying to build up our service, and there's nothing else I'd rather be doing. It's just it's really been this subspecialty of psychiatry is really kind of where I'm meant to be, for sure. Yeah.
That's really incredible. I do want to touch on suicide awareness. In your particular role, how often do you come into contact with someone who is having an episode that you are seeing this could potentially be a concern?
Yeah, daily, multiple times a day. That's pretty. So there's, I touched a little bit on kind of the role of psychiatry in the inpatient medical world and as a consultant and helping the medical team manage the needs of patients that are admitted medically. But as far as the ER, my work in the ER, is pretty much every patient I see, there's some risk of suicide or self-harm as a component in their presentation. And so emergency psychiatry is a subspecialty of psychiatry, and that's really a big part of, one of the biggest parts of what we do is assessing the risk for suicide. And there is a whole, field of science behind suicide prevention, suicide risk assessment, and this, wouldn't have enough time here today to explain all the nuances of how we do that. But it is a large part of what we do on a daily basis is talking to patients and evaluating their risk factors and their current, what they're currently telling us about their mental state. And, is that person in need of a higher level of care, or could they potentially be managed in a lower level of care, like the outpatient setting? So that's 90% of what I do in the ER, I would say, is assessing suicide risk.
Okay, so first, I had no idea that it was that prevalent. And I think that really highlights the importance of this prevention. And you were even talking about the science that's behind it. So from a clinical perspective, you are so equipped to be doing this work. What about those of us who, have people we love, we care about in our lives? How do we notice those symptoms to maybe be that one step ahead of, keeping them out of a clinical setting, if at all possible, to prevent? Sometimes the need is to go into. But, what can we look for? What difference can we make?
I think, there's lots of things to look out for, but if this is one of the biggest risk factors that we look at, one of the things that is one of the largest red flags for us is a prior history of self-harming or a prior history of suicide attempts. So if you have a loved one or a friend that you're aware of in the past, it could be 15, 20 years ago, but you're aware that they struggled with suicidal thoughts and at one point may have even attempted to end their life, that is one of the biggest predictors of future suicidal behavior.
Okay.
So if you know that is in someone's history and in their past, not that you wouldn't take their statements seriously to begin with, but anytime any change in behavior or concerning statements, you need to kind of take those very seriously.
Okay.
As far as kind of just the general public, as far as what to look out for, of course, concerning statements. People stating things like, I just wish I wasn't around anymore, or life would be so much easier for everyone around me if I wasn't here. Those types of things are concerning. Also, people that, a lot of times, if they're considering, suicide, there may be attempts to reach out to people they haven't spoken to in a long time and saying goodbye, things like that.
Yeah.
Or selling their belongings, those sorts of things. Giving away items that maybe you would expect would hold special significance to them. They're giving those away to loved ones, that sort of thing. That's a very concerning, red flag. And of course, just overall shift in demeanor and mood. If they seem very withdrawn, isolating, that's cause for concern. And, I think a lot of people shy away from this topic. It's still very stigmatized and taboo in a lot of settings. But asking somebody how they're feeling, where are you at right now?
Yeah.
That can go a long way. A lot of people with suicidal thoughts and suicidal behaviors feel alone and as though they're a burden on others. And showing someone that you love or that you care about that they're not can go a long way. Another thing I think is important to note is that suicide and suicidal behavior is a crisis-driven act. And if you can interrupt the crisis long enough, you can kind of steer things in a different direction. And this is backed up by research. There was a study done on survivors of suicide attempts from the Golden Gate Bridge. They studied
I read this.
Yeah. And so they studied, I think, 300 people that had either had a suicide attempt interrupted on the Golden Gate Bridge or had even attempted and then survived. And they did a longitudinal study and they followed these people, and 20 years later, 94% of them were still alive.
Wow.
And so what that shows you is you interrupt the crisis, you interrupt the individual's plans long enough, and you can get them the help they need, and you can funnel them into the appropriate resources. The chances for long-term survival are huge, you know? So
So it's attention. It is just paying attention, really seeing the people that you love. And honestly, like the people that you're around a lot. Like I think of how often you think of a work day. How often are you around your coworkers and we get to know them and you get to know their quirks and how they tick and how they interact. And even that, I think, you know, if that changes, that would be a major red flag.
Yeah.
This is so helpful. And I love how tangible some of these things are, how really practical they are to be able to do. Your work is so important. I really appreciate you coming here. I do want to ask, is there anything I haven't asked that you would like to speak to?
I would just say that if you have concerns about a coworker, a friend, a loved one, and you're worried that they either you have suspicions or you know for a fact that they are planning something to harm themselves, there are ways to get people into help. You know, additionally, if you yourself are having thoughts of that are concerning for you, thoughts of wanting to end your life or to harm yourself, there's the last year or year and a half or so ago, the 988, the suicide hotline. That's it's a national number now that you can call, and they can get you into the appropriate setting to be evaluated. Also, our emergency department, you know, if you have concerns for someone, you can ask them to come into our emergency department to be evaluated. Don't suffer in silence. There is lots of help available, is what I would say.
Thank you so much. And thank you all for joining us on And So Much More.